What a fantastic evening, my dear friends. Welcome, one and all. This is Dr. Vijay Chetty, CCI Webinar Coordinator, and it's a proud feeling to moderate CCI webinars. And today it is my job. I was asked by Dr. Shivani very clearly that you need to do one webinar, for in the COPD series. I told with very tight schedules, it is very difficult, Shivani. So then what she said is, she asked initially me to moderate the NIV and mechanical ventilation, ICU management, this session. But in the last minute, the topic has changed. And then she has given me a few days back the task of COPD comorbidities, the hidden aspects of breathlessness and beyond. So, to be honest, many times we, the pulmonologists, we focus more of spirometry and probably our lung function testing, 6-minute walk test and all those things. But there is a saying, as we reach more to the tree, we will lose the vision of the entire forest. So it is not correct. The correct attitude is, let's have a bird's eye vision of how to manage COPD and without managing the comorbidities, it is always a incomplete task. Today, we have a wonderful panel. We have a panel from Gujarat, expert from Gujarat, Kolkatta and Karnataka. So let me introduce first Dr. Shachi Pandit. I welcome Dr. Shachi Pandit. We are proud to have you, ma'am. And she is a well-known pulmonologist and critical care specialist from Narayana Multi-Speciality Hospital, Ahmedabad. And Dr. Debraj is supposed to join, but he is stuck somewhere. He is expected to join us anytime. He is one of the renowned consultants from Kolkatta. And Dr. Hirenappa Udnur, my good friend, and we are friends for the past close to 15 plus years. And is a wonderful pulmonologist and great mentor to youngsters, and currently practicing as a pulmonologist, senior pulmonologist with Manipal hospitals. He is a serial entrepreneur as well, and he also practices at Inspire Chest Clinics. Welcome, my dear friend.
Thank you.
And entire India is looking forward to listen from you of how to manage comorbidities. Another good friend and native from Davangere, our Krishnana's place. Looks like young, but not really young. He is very well matured pulmonologist, and currently practicing as a chief pulmonologist at Shachi hospitals in Davangere, Shimogga. Welcome, Dr. Amitash M P. So we are really truly honored to have you, all three of you, on board.
Thank you, sir.
And my dear friends, today the schedule is very clear. I'm going to talk roughly around 15 to 18 minutes on a topic of pulmonary comorbidities. Then followed by Dr. Amitash will talk on systemic comorbidities and how to manage. These two talks will be followed by wonderful panel discussion. So next 1.5 to 2 hours, please stay tuned to the same channel. And today we will be having an academic feast. Any doubts you come across, Please do not hesitate. Please do post us. We will clarify all your doubts. Meanwhile, I must thank Dr. Ashish Dubey, our National President, Dr. Anil Maske, National General Secretary, Krishna Anna always, and Narayan Pradeepa, our entire core committee, Atri Gangopadhyaya, Ravi Dosi, Shivani, Kirat, and entire team, Agambai, okay, for their relentless support for the past 5 years in running this academic show back to back. And I will be talking, allow me to share my slides. I'll be talking on pulmonary comorbidities for next roughly around 18 minutes or so. Hope my slides are visible. Right. So without wasting much time, okay. So I practice as senior intervention pulmonologist from Apollo Group of Hospitals, Apollo Jubilee Hills, Health City, Hyderabad. And I'm very much known for my intervention skills, especially thoracoscopy and bronchoscopic interventions like EBURS. And with this, now I would, COPD we all know. So we have covered so far this is a series part number 4. Okay. We have covered all the basics, inhalers, oral medications, all this so far. Now today we will be talking on comorbidities, and COPD is a heterogeneous lung condition primarily characterized by presence of airflow limitation due to abnormalities of the airways under alveoli that often coexist with other chronic diseases. These comorbidities pose a very significant challenge in the assessment and effective management of COPD and are also known to have health and economic impacts as well. And what is important is significant local and systemic inflammation, which have been proposed as having a potential role in explaining the association between COPD and these comorbidities. And if in this scenario, if I forgot to mention the war that has happened between India and Pakistan to erase the terrorism, the contributions from India to erase terrorism, okay, is significant. And I must highlight to make you understand this S400, that is Sudarshan 400, has been applied very well in earlier wars as well, that is the war between Ukraine and then Russia. But the overall output of Sudarshan 400, S400 was a failure in that war because the Ukrainian people could easily tackle this weapon. But what has happened in the war that has happened between Pakistan and India, if you see, so this is what we need to understand. So the Sudarshan 400, so the schematic of typical air defense system will look like this. So what we need to understand is, this is the launch vehicle, number 3. Number 1 is long range surveillance radar. Number 2 is engagement radar. And this one, unlabeled one, is a command vehicle. So the job of an air defense system is to project a region from attacking, to protect a region from attacking aircraft or a projectile. So thus, we need to understand the first one, the long range surveillance radar, so which will help in detecting intruding enemy or aircrafts or missiles or drones. And the second one is engagement radar. So that is tracking radar to engage own intercepting missiles. That means, so we should also, we are also sending a lot of missiles from our land to other foreign nation. So we should also track these our own land missiles, and we should ensure that we are not obstructing our one, and we should all only obstruct or destroy the enemy drones, aircrafts, and missiles. So, and the missile system, the third is the missile system, which is a to launch intercepting missiles to destroy enemy once midair. So whatever that is coming from the opponent, we have to detect and then neutralize then and there in the air itself. So for which this command vehicle plays a very, very crucial role. So I find that the subsystem specifications of S-400 show a very good coverage on different fronts. So what has happened is these surveillance radars and engagement radars were of poor quality in Russia-Ukraine war. But whereas our Indo-Pak war, our indigenous system of technology has been, now we know that it is one of the best, and it emerged as a leader in entire Asia. Now with this war, we have proven to the world that we are the leaders in the Asia and probably the global market. So we could neutralize all the drones because of this effective system. So the launch vehicle, the analogy I want to mention here is the launch vehicle is not alone enough. Here it is compared to COPD. We should also identify, we should also have the additional systems, that is management of comorbidities, for making it as a successful mission. So here if you see the in COPD, there is a lot of local and systemic inflammation, which leads to a lot of inflammatory mediators in the system, and then loco-regional as well. The loco-regional inflammation leads to bronchiectasis and lung cancer, and to some extent sleep disorders, whereas the systemic inflammation leads to sleep disorders, metabolic syndrome, and cardiovascular disorders as well. So one of the important things what we come across in practice is presence of pulmonary hypertension. So development of pH in COPD has been described as mild to moderate in severity with increasing incidence as underlying lung disease progress. The WHO classifies COPD pH into group 3 pH secondary to chronic lung disease and hypoxia. The pH in lung disease negatively impacts the disease trajectories through worsening hypoxia, reduced functional capacity, and increased mortality. So what we need to understand the various mechanisms we know. The pathophysiology includes hypoxic vasoconstriction, which plays a role, but the molecular mechanisms which are driving vascular remodeling inherent to pulmonary arterial hypertension are also seen in pH in COPD. That is endothelial dysfunction, fibroblast proliferation, dysregulated angiogenesis. On the same time, cigarette smoke appears to stimulate key contributors to vascular remodeling, including decreasing endothelial nitric oxide synthetase, increasing mitochondrial oxidative stress, and decreasing prostacyclin synthetase. So these are the various mechanisms. And let's see, in a normal patient, the hemodynamic classification of pH in COPD includes normal, the mean pulmonary artery pressure is less than 21, or if at all if it is less than 24, the PVR should be less than 3 Wood units. And in patients with pulmonary hypertension in COPD, the mean pulmonary artery pressure is 21 to 24 with the pulmonary vascular resistance more than 3 Wood units, or mean pulmonary artery pressure 25 to 34. To classify them as a severe pulmonary hypertension patients, we need to have mean pulmonary artery pressure greater than 35, or in presence of greater than 25, the cardiac index should be 2 liters per minute per meter square. And what we need to understand, though, in COPD patients, there is some of the patients will have proportionate pulmonary hypertension, and some of the patients what will have is out of proportion pulmonary hypertension, which can be contributed by pulmonary arterial hypertension. So we need, for assessment of pulmonary hypertension, it is very, very important to look into various factors. We should rule out chronic thromboembolic pH by doing angiogram or VQ scan. Left heart disease should be ruled out. Sleep breathing disorders should be ruled out. Risk factor for coexistent pulmonary artery hypertension like HIV infection, BMPR2 mutations, portal hypertension, CTDs should be ruled out. Pulmonary function testing should be done. Imaging should be done appropriately. Right heart catheterization, if there is a need, we have to do to identify mean pulmonary artery pressures and cardiac index. And CPET also will help in to some extent, where cardiovascular limitation pattern can be observed, preserved ventilatory response can be seen, or gas exchange inefficiency as evident by low end-tidal CO2 or high VE by VCO2 slope. And circulating biomarkers like BNP or NT-proBNP should be monitored. So what we need to understand, so in COPD with pulmonary hypertension patient, the risk of mortality without pulmonary hypertension, the risk of mortality is very, very low. In those patients with post-capillary pulmonary hypertension, where pulmonary arterial wedge pressures are more, and then in mild to moderate proportionate hypertension, these are the patients will have moderate mortality risk. But what we need to understand, my dear friends, please note the pulmonary vascular phenotype is very, very dangerous phenotype. The FEV1s here is may be very, very borderline low, whereas the mean pulmonary artery pressures are very, very high. So in this group of patients, it is very, very important to identify the appropriate phenotype and manage these patients as early as possible to decrease the mortalities. And overall, once the COPD patients are identified, if they have the history suggestive of pulmonary hypertension, thorough assessment with PFTs, imaging and exercise testing and echocardiogram is needed. And we need to do invasive pH confirmation by doing right heart catheterization in patients who are candidates for surgery or suspicion of severe PAH, or if we want to rule out left heart disease. Here, we need to identify if mean pulmonary artery pressure is less than 20, then there is no pulmonary hypertension. We need to manage our COPD patients as it is. And if the mean pulmonary artery pressure is greater than 20, the proportionate pulmonary hypertension patients manage with COPD and consider long-term oxygen therapy. And if there is a coexistent pulmonary arterial hypertension, we should treat with targeted PAH therapy, that is pulmonary vasodilators. And if the patient is having left heart disease, as evident by pulmonary arterial or pulmonary capillary wedge pressure elevated, then we need to manage the left heart disease to manage the pulmonary hypertension here. What is very, very important is, once the pulmonary vascular phenotype is seen, it is always advised not to manage at a small centers. It is better to include in randomized control trials or consider treating these patients with targeted pulmonary hypertension, arterial hypertension therapy in an expert center only. So Gold says very clearly, the preferred option to manage is initial monotherapy followed by careful sequential combination therapy. And when CTEP is diagnosed, the patient should be managed in a multidisciplinary CTEP team. In patients with non-severe pulmonary hypertension, COPD, the use of pulmonary arterial hypertension medications is not recommended. And in patients with severe PH COPD, an individual approach is suggested. So, the results of PERFECT trial, the treatment with inhaled treprostinil showed no clinical efficacy, but was associated with the potential adverse events. So, the inhaled treprostinil is contraindicated. Further, well-designed randomized control trials should be encouraged to firmly advise for or against use of PAH medications in pulmonary hypertension COPD. Coming to quickly, bronchiectasis and COPD. So, we know bronchiectasis as a chronic airway disease in which bronchi become progressively and permanently dilated, and the vicious cycle as it is evident, the first initial infection lead to a lot of inflammation, leading to, in presence of impaired mucociliary clearance, lot of airway mucus hypersecretion and obstruction lead to microbial colonization like Pseudomonas, Staph aureus, Haemophilus, lead to bronchial dilatation and airway destruction. And this has become a vicious spiral, and it is becoming very nuisance in management of COPD patients. Otherwise, if we don't identify this component early, then the chance of having a recurrent exacerbations because of infection is very common in bronchiectatic patients. So, as said, the evidence says close to 30% of patients with COPD will have bronchiectasis. But what we also need to understand, in severe COPDs, the chance of having a concomitant bronchiectasis is close to 80%. And various CT patterns and D'Souza and Doe et al., they said in presence of bronchiectasis, there is a frequency of hospitalization, exacerbation rates, lung function severity, ambulatory visits are increased in patients with bronchiectasis and COPD overlap compared to patients with bronchiectasis alone. So COPD patients with concomitant bronchiectasis present with worse pulmonary function and a higher emphysema index score, higher proportion of pulmonary hypertension and cor pulmonale than patients without bronchiectasis. So Nigro et al. Has suggested the bronchiectatic COPD overlap patients will have high level of inflammatory cytokines, while ILT10 expression levels were lower than those of the control group. The serum level of adiponectin, a new biomarker of COPD, increase in the levels of adiponectin in patients with BCO, which is probably related to their worse airway inflammatory state. So, coming to summary of evidence here for bronchiectasis patients, airway mucus hypersecretion is associated with an accelerated lung function decline, higher rate of hospitalization, and bacterial and viral mediated acute exacerbation in patients affected by COPD. And what is important in these patients, whether we can use inhaled corticosteroids or not is a debate. Those patients who have peripheral eosinophilia, still they may get benefited with inhaled corticosteroids. Otherwise, there is a very likelihood chance that they may get increased rates of pneumonias and exacerbations because of usage of inhaled corticosteroids. Other interesting overlap we need to identify in practice is OSA and COPD. We know what OSA does, and then the sleep disordered breathing leads to a lot of sympathetic overactivity, sleep fragmentation, intermittent hypoxia, upper airway inflammation and GERD, and overexpression of pro-inflammatory cytokines. Whereas COPD leads to arousal due to chronic cough and pain, microaspirations and GERD, tonic hypoxia, upper airway edema, and lot of pro-inflammatory cytokines, ultimately leading to lot of systemic inflammation in this combination of patients. So, what does COPD cause? COPD is marked by daytime hypoventilation, hypercapnia, and sustained hypoxemia, whereas OSA will cause nocturnal apnea and desaturation. Ultimately, skeletal muscle atonia, diaphragmatic weakness, and hyperinflation may further worsen the nocturnal ventilation. So, what is happening eventually? These patients, because of sleep apnea, they are hard to breathe during sleep. And then during awake, because of COPD, they are finding hard to breathe during awake. So ultimately leading to high hypoxic burden, increased cardiovascular strain, and worsened cardiac outcomes. And so how to manage? So if there is an evidence of hypercapnia or not. If there is an evidence of hypercapnia, so is not there, then if the patient is sleepy, or if the patient is having high risk occupation, or if the patient is having subtle or quasi-symptomatic features and then sleep-related complaints, probably a trial of CPAP can be given. But what happens in asymptomatic patients? If the patients who are having very less symptoms, these patients, we should look for any comorbidities like pulmonary hypertension, CVA, or high hypoxic burden, or severe OSA. These are the patients you can give a trial of CPAP. But in which patients you are going to give BiPAP or NIB? That is very important. In those patients who have persistent daytime hypercapnia and BMI greater than 30 kg per meter square, these are the patients likely to get benefited from nocturnal NIV. So please understand the survival percentage and exacerbation-free survivals in presence of this comorbid, that is OSA. In the COPD patients, and then is compared with plain COPD and those patients who are overlapped with CPAP and overlap without CPAP. It is always shown both the survival and exacerbation-free survival in these populations are plain COPD patients are minimal, and then those patients who are treated with CPAP, when the overlap is there, so they are doing better when compared to those patients who were not offered with CPAP therapy. So inhaled triple therapy, again, the impact of sleep quality in these patients with COPD was evaluated, and when compared budesonide, formoterol, tiotropium versus placebo, tiotropium, the triple therapy improved the pulmonary function while preserving the sleep quality and architecture. Coming to another important comorbid, that is lung cancer. So it is very, very important to understand both the pathogenic mechanisms and then risk factors like smoking, air pollution. So they are closely interrelated in both the group of patients. And COPD and lung cancer, if you see the overlap, 15% of smokers develop COPD. And 40 to 70% of lung cancer patients have COPD, and 10% of smokers develop eventual lung cancer. But what is important we need to understand is COPD confers 2 to 7 greater risk of fold greater risk of developing lung cancer independent of smoking history. So a lot of genetic mechanism can lead to both together, and lung microbiome in COPD and lung cancer play a very, very crucial role. We'll discuss in panel discussion. So 3-year survival rates in this comorbid, that lung cancer comorbid, is in general population versus COPD patient. If you see, in those patients who doesn't have a COPD, they tend to fare very well on 3-year follow-ups. And screening is an important tool in COPD patient to detect the lung cancer. So low dose CT scan and spirometry regularly is very, very important. In some centers, they do offer genetic screening for SNPs and analysis of exhaled breath condensate for biomarkers, and ensure spare extra 2 minutes of your clinic time in advising the smoking cessation in these patients. And then inhaled corticosteroids have shown beyond doubt they are going to significantly decrease the risk of lung cancer when COPD patients are managed appropriately. Coming to another interesting, that is ILD. Pathogens of CPFE is multifactorial, and emphysema and pulmonary fibrosis are both recognized as primarily driven by smoking, and most CPFE patients appear to be either current or former smokers. The correlation between CPFE and PAC-ES supports a dose-responsive relationship. And the common age is 65 to 70 years. Cough and dyspnea are predominant. And we will see Velcro sounds along with finger clubbing in clinical examination. The classical pattern is upper lobe predominant COPD and then lower lobe predominant ILD. This is a CT which shows a lot of centrilobular emphysema on the upper lobe, and there's a lot of traction bronchiectasis and subpleural predominance of honeycombing, so which is classical of CPFE combination. So, and the treatment, so there are no guidelines for CPFE as of now. As of clinical experts' opinion, it is very, very important to treat COPD and then pulmonary fibrosis together. And ICS LABA, triple therapy when there is a eosinophilic variant, bronchodilators, pirfenidone, nintedanib, the antifibrotics, mirtazapine is going to help in decreasing breathlessness in this patient. And to increase the pulmonary arterial compliance, tadalafil has proven to be a significant role. COPD GERD is another important component. So GERD prevalence is almost in 30 to 60% of patients we have seen. And it is shown that those patients who have got GERD are having more amount of exacerbations. So that's why It is very, very important. And then systematic reviews have also shown that those patients, when GERD is managed with PPIs and prokinetic agents, their exacerbation frequencies and mortalities are decreased. And so last slide, the pulmonary comorbidities are not side notes in COPD. They are central chapters in its story. Conditions like bronchiectasis, pulmonary hypertension, lung cancer, sleep apnea, and even recurrent infections are not rare co-travelers. They are common, consequential, and often underdiagnosed. Each of these adds layers of complexity, more symptoms, more exacerbations, more mortality risk. For example, coexisting bronchiectasis can fuel a vicious cycle of infections, while undiagnosed OSA can worsen nocturnal hypoxemia and heart strain. And how often do we miss the early signs of lung cancer, attributing everything to the usual COPD symptoms? Moving forward, we must train our clinical lens to look beyond the airflow limitation. The future of COPD care is not just about stepping up bronchodilators or treating everyone with triple therapy. It's about stepping back and seeing the whole pulmonary landscape. Let's start routinely screening for these conditions, integrating multidisciplinary insights and tailoring therapy beyond the conventional inhaler. And I hand over mic to Amitash for delivering his talk on systemic comorbidities in COPD.
A very good evening to one and all. Myself, Dr. Amitash. I'm a consultant pulmonologist in Shimogga. I'm very thankful to Chest Council of India for selecting me for this COPD webinar series part 4. The topic of discussion today is COPD comorbidities, the hidden aspects of breathlessness and beyond. I'm pretty sure Dr. CVK sir would have covered about the pulmonary comorbidities. So let us dwell more in detail with regard to extrapulmonary comorbidities. So these are the various diseases that coexist with COPD, and they have a lot of effects on the COPD course, management, and prognosis. Few of these conditions are arise independently of COPD, and few are causally related, maybe because shared factors like age, smoking, and activity. One disease will increase the risk of other, and they compound the severity of the other. They share a lot of clinical features of COPD, thus making the differential diagnosis pretty difficult. For example, the cardiac conditions. As COPD is affected by comorbid conditions, COPD itself is a significant comorbid condition, which negatively affects the management of other diseases. So the presence of comorbid conditions should generally alter the management of COPD, and it has to be managed along with parallelly with other comorbid conditions. The special point to note here is these comorbidities can affect any severity of COPD. It is a misnomer like usually in the higher grades of COPD or the severe COPD only the comorbid conditions are affected, which can affect any of these severities of COPD. So this is one of the article which was published in 2022 in Tuberculosis Respiratory Disease Journal. It shows the prevalence of the comorbid conditions with regard to COPD. As you can see here, a lot of varied percentages are there, but quite commonly the most common are hypertension, coronary disease, diabetes, osteoarthritis, gastroesophageal reflux diseases, and various other comorbid conditions. This one more project which showed like more than 94% of COPD patients are affected by one or the other comorbidities. Some 46% of patients more than 3 or more comorbid conditions. Here again, it showed the arterial hypertension, the metabolic syndrome, cancer due to any cause, and diabetes mellitus as the most common comorbid conditions. Here, as I told in my first slide itself, all the stages of COPD severity. When this study was published in 2013, the stages were like gold 1, 2, 3, 4 as per the spirometric gradings, but not ABCD as we use nowadays. But again, you can see in all the severity stages, these comorbid conditions are affected. As the comorbidities increase, as you can see in the below graph, the COPD exacerbation rates are also increased. This is one more article again. Here also it shows a lot of patients of COPD had comorbid conditions. As we go through the detail of these graphs, here you can see the symptomatic COPD patients, so the group B and the group D patients. These are the patients who are most commonly affected by comorbid conditions. As you can see, the hypertension, it is more commonly in the group A and group D. The obstructive sleep apnea, again, these two conditions. The dyslipidemia, again, these two. So as the patients of COPD are more symptomatic, they have a lot of comorbid conditions along with that. So as we understand the prevalence of these comorbid conditions, let us understand why these comorbid conditions are there, what are the pathophysiology behind these comorbid conditions, and how it affects the COPD management as well. So these are the articles which I have taken it as reference. The review article in European Respiratory Journal, the respiratory medicine, the article for regarding GERD in the COPD management, the latest guidelines regarding the GERD and the COPD management from 2024 Respiratory Investigation Elsewhere Publication Journal. So the most common comorbid conditions as we discussed was the cardiac comorbid conditions. So COPD, by virtue of being a systemic inflammatory disorder, has an endothelial dysfunction, and there are reduced number of something called the cellular endothelial progenitor cells, especially in the pulmonary circulation. So by virtue of following all the three criteria of which was tried, like the endothelial dysfunction, the increased coagulability, and the vascular stasis, COPD is a procoagulant state. There are a lot of increase in the tissue plasminogen levels. Factor 7A, fibrin clutch is difficult to lyse. So there are a lot of thrombin, antithrombin complexes, inflammatory mediators like IL-6 are secreted. This cycle goes on happening recurrently because systemic inflammation, oxidative stress, recurrent hypoxia, continued smoking. So all this contribute to the recurrent procoagulant and the pro-inflammatory cascade. With regard to pulmonary hypertension, by virtue of hypoxia, hypoxic vasoconstriction, destruction of pulmonary capillary bed by emphysema, smoking-induced inflammatory infiltration, and the shear stress, it contributes to pulmonary hypertension. It is beyond the virtue of this class to discuss about the severities of pulmonary hypertension. As I mentioned in the previous slide, a lot of inflammatory markers are there: interleukin 1, tumor necrosis factor alpha, interleukin 6. These inflammatory markers share the common pathophysiology in case of coronary disease as well as COPD. This go on happening recurrently in this kind of patients, so they're more prone to myocardial infarction. The same risk factors like smoking, inflammation, and skeletal muscle alteration again contribute to something called heart failure. So these cardiac comorbidities are the part of coagulation cascade in the inflammatory cascade in case of COPD patients. So these are most common, most easily diagnosed, but often we overlook this due to similar clinical features. And these contribute to larger extent of mortality and morbidity in case of COPD patients. So the second comorbid condition is anxiety and depression. They may not be sharing the same pathophysiology of COPD patients, but again, when these are present, they have a lot of effect on the management of the COPD condition. So old age, the exercise limitation contribute this anxiety and depression. Most of the studies are on cause of depression, which is at the higher prevalence rate of around 20 to 42%. It has a prognostic value as well because these patients have prolonged admission, these patients have poor symptom control, they have recurrent hospitalization, and this has a negative prognostic value, high rates of mortality. Osteoporosis, again, because of old age, decreased mobility, smoking, some sort of bone remodeling mechanism is affected. Vitamin D deficiency is also there. So this contributes to osteoporosis in COPD patients at very higher levels. So WHO studies show somewhere around 24 to 69%. These patients, because of osteoporosis, in old age, they undergo something called vertebral fractures, which decrease the FVN and lead to restrictive physiology in case of COPD patients. Malnutrition, till recently, the BMI was considered as the rate of malnutrition, but assessment of lean body mass is more important nowadays, other than the weight criteria. Skin fold thickness, even if it's a bedside test to assess the lean body mass, it's inappropriate in elderly. So bioelectrical impedance assessment is much better. Malnutrition may be because of imbalance between the low energy intake and the increased energy consumption. Fatigue during food intake, impaired lectin regulation, increased work of breathing. They'll be having some drugs like theophylline, doxorubicin, deriphyllins, and beta blockers, which have high metabolic rate. Increased protein catabolism due to systemic inflammation, hypoxia, and smoking. So this creates this imbalance and cause a lot of malnutrition. Higher rates of COPD, higher prevalence of malnutrition, and it has a negative predictive prognostic value as well. So a lot of higher rates of mortality are seen in case of COPD patients. Obesity, this is again the most important comorbid condition associated with COPD. Smoking, systemic inflammation, pro-inflammatory cytokines contribute to insulin resistance. By virtue of this morbid obesity, they contribute to some sort of restrictive physiology. Other pathophysical mechanisms which are postulated are reduced pulmonary elasticity due to non-enzymatic glycosylation of tissue proteins, loss of inspiratory muscle strength, diaphragmatic compressed due to diabetic neuropathy. It is again a recurrent pro-inflammatory pro-coagulant state. So it causes recurrent infective exacerbations, prolonged admission. So some studies though mention like BM as a protective effect on lung function, but again, this effect is overcome in case of morbidly obese patients. Anemia, malnutrition, old age, and comorbid cardiac illness because alteration of renin-angiotensin system. The interleukin 1, interleukin 6, TNF alpha alters some erythropoiesis. So, lot of COPD patients in severe grades have severe anemia. It is an independent negative predictor of COPD exacerbation mortality. It has a prognostic value as well. So, a lot of recent studies have assessed about the GRD. The hyperexpansion displacing the diaphragm, increased transdiaphragmatic pressure seen in severe airflow obstruction, alter atomic tone of the lower esophageal sphincter. It may be because of COPD as well as consequence of short-acting beta agonist. A lot of steroids are used in case of acute exacerbation. These contribute to a lot of regurgitation, the reflex, and the aspiration of this reflex, cholinergic mediated esophageal bronchial reflex. They cause a lot of significant role in pathophysiology of GRD. GRD will increase the exacerbation in case of moderate severe COPD patients. One possible hypothesis of the interesting study mentioned like the PPA antagonist and the H2R receptor antagonist, they increase the rate of aspiration because most of the reflex in COPD is non-acid reflex. So thereby contribute to more exacerbation. But the recent study, 2024 study has not proved this. Lansoprazole, few of the studies shows a better acceptance in COPD patients, but any of the PPA antagonist and H2R receptor antagonist can be used. Various other contributions of comorbid conditions like atrial fibrillation, arrhythmias, chronic kidney disease, these are seen in COPD. They may be alone or sometimes they may be associated with cardiac comorbid conditions. So, as we discussed, COPD will contribute to the lot of ill effects of comorbid conditions, and the comorbidities will lead to a lot of exacerbations in case of COPD patient. This was put in a large study called Eclipse study, where they separated the patient as two phenotypes. One phenotype is a severe obstructive syndrome without or less comorbid conditions, and the other phenotype is a moderate obstructive syndrome with a lot of comorbid conditions. So the second phenotype had a lot of exacerbations. So comorbidities contribute to a lot of exacerbation rates. So how do you approach to the patient? So most of the times it's a pragmatic approach because when the patient is in front of you, you cannot go with the guidelines. It is a practical approach which we have to take for the patient. Especially with regard to cardiac comorbid conditions, we should have a low threshold for suspicion. A lot of symptomatic assessment like orthopnea, PND, pedal edema, a lot of these conditions will help. The routine blood investigations like CBC, CRP, because advanced markers may not be required all the times, may not be available as well. Full LFT, including albumin, this also will help. In case of doubtful assessment or to prove the cardiac comorbid conditions, TROP5, proBNP levels, and D-dimer levels. If you suspect pulmonary thromboembolism, the CT pulmonary angiogram. Most of the patients of COPD may not be able to complete the TMT test because of the excess limitation. So stress-induced echo, especially the dobutamine-induced echo, are more commonly used. In special cases like ureoscopy, osteoporosis, bone density assessment, lean body was bioelectrical impedance assessment can be done. So regarding management of COPD patients, it is a multidisciplinary approach. Various experts may have to be involved sometimes. So treatment of underlying COPD will be the first concern. Management of comorbidities along with that. The cardioselective beta blockers have an effective role in case of COPD with heart failure and myocardial infarction. There's a lot of misconception regarding the usage of this. Even few studies shows that non-cardiac selective beta blockers can also be used, but it is worthwhile to use the cardioselective beta blockers. Other comorbid conditions can be treated appropriately. There are a lot of apprehension regarding the usage of the beta-adrenergic agonist, especially the salbutamol, the shorter ones, the LAMA, especially the tiotropium, with regard to cardiovascular risk factors, arrhythmias, and coronary disease. Studies have proven better safety profile with salmeterol, indaketrol, lycopyrenium, formoterol, Tiotropium has slightly higher risk, but the recent Lama, the Gakugan has a better safety profile. Anemia, malnutrition, osteoporosis, GIRD should be effectively treated. Vitamin D supplements can be given. Anxiety depression in case of moderate to severe cases, it's better to involve the expert. So better symptom control, better exacerbation control will be taking place. Statins, initially there was a lot of studies advocating its benefits, but nowadays, unless it is associated with cardiac comorbid conditions, statins may not be useful in the routine management of COPD cases. Diabetic and metabolic syndrome appropriately managed. Few studies mention special question regarding metformin, especially in the acute respiratory failure conditions, sepsis and AKA, as they can prescribe lactic acidosis. But long-term studies does not show any clinical adverse effects. Diuretics, except in acute exacerbations and specific pH therapies, may not have a long-term role. In case of moderate pH, the patient is not maintaining saturation. Effective bronchodilator therapies, after effective bronchodilator, pulmonary thrombolysis should be suspected. NAV bypass in COPD OSA overlap. What I feel is all obese COPD patients with 2 or 3 comorbidities should be screened for OSA evaluation. Smoking LTVT as a survival benefit. Vaccination should be allocated to all patients of COPD and regardless of the grades of severity, because they help in preventing the infective exacerbations. Pulmonary rehabilitation, especially when started doing the acute exacerbation admission, as the better acceptance rate and will lead to decrease in exacerbation and an increased excess capacity. So this is the broad overview of the comorbid conditions, extrapulmonary comorbid conditions, COPD patients, how to approach them and how to manage them. So other things in detail, the specific questions in detail can be discussed again in the panel discussion, where we have expert panelist joining with us today. So I hand over the further proceedings to Dr. CVK sir to take up further and to the panelists further. Thank you.
Dr. Amitash, that was a fantastic talk. Fantastic talk. Really, all minute points regarding comorbidities you have covered very well. Particularly, there's a lot of clarity now our audience has got. So, thank you. Welcome once again, Dr. Hirenappa, Dr. Shachi, Pandit. Let me look at the questions. First of all, there's immense appreciation from the core committee that there is 1,000+ logins already who are watching us, and we have questions pouring down. So, Dr. Sunil is asking, Dr. Sunil Dingra is from Haryana, Faridabad. Do COPD patients improve better with CPAP or BiPAP? I will hand over this question to Shachi Pandit, Dr. Shachi Pandit.
Yeah, hello. Am I audible? Yeah.
Yeah, you are loud and clear.
Yes. So I would say if patient is having overlap syndrome, OSA with COPD, definitely, but with COPD, if patient is not having chronic type 2 respiratory failure, then patient can be managed with CPAP alone. But yes, if patient is having OSA with COPD with chronic type 2 respiratory failure, then I would suggest this patient to be managed on BiPAP. And alone, if patient is having COPD with chronic type 2 respiratory failure, then definitely only BiPAP will work. CPAP won't work in such patients.
That's what. Thank you, Dr. Shachi, for brief explanation. I have also explained in one of my slides, which states very clearly, if the COPD patients who are having concomitant obstructive sleep apnea, who are symptomatic, or if they are minimally symptomatic, then please watch for, is there any additional comorbidities like carpal pulmonary hypertension, or the patient is having CVA. Definitely, they would be the ideal candidates for PAP therapy. There is no doubt. Probably we can manage most of the time with CPAP. But if these patients are having a morbid obesity and then type 2 component, daytime hypercapnia, these are better managed with BiPAP. Thank you, Dr. Sunil Dingra, for asking such a wonderful question. And coming to our Dr. Hirenappa, so in your practice, how early should we screen for cardiovascular disease in COPD patients? And what is your take on this?
So most of our patients are more than 40. COPD occurs in middle age group. Unless there are alpha 1 antitrypsin deficiency and those kind of features. So middle age disease,
Your voice is slightly low, my dear friend.
Yeah.
You are now loud. Please go ahead.
Yeah, if his COPD patients are normally middle-aged, middle-aged patients and young patients, unless alpha-1 antitrypsin, they don't require much of the screening. Most of them are smokers. The risk factors for cardiovascular disease is also smoking and obesity, all those risk factors. At 40, 45, we start developing these risks. Anyway, they have to screen for cardiovasculars, like they need a TMT and cardiac evaluations as a health checkup. They would have been doing this. But in a patients who are COPD, who are diagnosed COPD at around 42, 43. So if they are having a risk factor, we obviously tell them smoking cessation and do all those things as a due diligence. We do. Initially, it presents like smoker's cough. Once they start developing breathlessness, if they obviously have a symptoms of chest pain and angina-like symptom, it's easy. We do regular screening. That's not a problem. We take a cardiology consultation. If the breathlessness you feel that it is really disproportionate, you need to evaluate alternative causes of breathlessness. If it is really explained by your PFT and the good response to treatment is there, it's okay. And if it is not, then we need to screen for cardiac this thing with ECG, TMT, and usually echo. That suffices. And usually we screen for all secondary effects of COPD also, or if there is an associated comorbidities for a risk factor with smoking, it helps in screening the COPD. Early, the day, time, it's very difficult. A clinical scenario will guide us. Somebody is obese with the stress factors, who is working in a high, good corporate job, smoking risk factors are more, then we should consider screening for cardiovascular disease in a COPD patient.
Right. I completely agree with you, Dr. Hirenappa. So, with particularly after 2020, I mean, post-COVID, there are a lot of deaths that we are seeing in otherwise even healthy individuals. It is always better to check for the associated cardiovascular comorbidities as an early screening than delaying it. The moment patient is not responding for your conventional COPD treatment, and better you get, whether it is mild COPD or moderate, severe, whatever it is, better to screen as early as possible if the treatment response is not good in early stages. If the patient is having severe COPD and moderate COPD, better to screen every patient, get your a referral to cardiologist, and then get them say that there is no or there is a yes cardiac component in this. Coming to Amitash, it was lovely listening to your lecture, but only small issue is you made the slides, the fonts were very tiny. Okay, next time my sincere request is to make it slightly more larger size. So I would love to ask you, what's the practical approach to distinguish, differentiate cardiac dyspnea from COPD exacerbations? And what is your take?
Yeah, am I audible, sir?
Yep.
Okay. As Dr. Hirenappa sir told, as I mentioned in my slides as well, it's a pragmatic approach more commonly. Sometimes the patient throw himself on our face regarding the symptoms as well. So he'll be having more of like edematous faces and edematous sputum edema and all. He'll have breathlessness, as sir rightly pointed out, is disproportionate issues of dyspnea. I usually keep a low degree of suspicion whenever a severe COPD patient was not effectively controlled on medications or who is coming for the first time with exacerbation to my setup, my clinical setup. So every first onset, I usually keep the suspicion of cardiac comorbidities at the first onset itself. If the patient is very low BMI side, if he's more having an emphysematous lung, where studies prove that more cardiac comorbidities are associated with emphysematous lung, for example, pH as well, as you mentioned in your slides as well. So with the basic investigations such as the ECG and echo, most of the times we'll be able to figure it out what are the cardiac comorbid illness. Uncommonly, very less instances, we have also treated the exacerbations. We have also made the patient to undergo the angiograms as well. I think CTCAG future guidelines may come if he's not into renal comorbidities. It may prove few of the coronary artery diseases, which are quite common. Few studies shows, especially when they're admitted into the hospital setup, more than 5 to 6 times higher incidence of coronary artery disease in case of COPD exacerbation compared to the general populations. So symptoms as well as the signs of the patient, the control of the symptoms as per the attendance history, whether he is really taking the inhalers properly or not. If he's not taking the medications properly, then yes, we'll treat the patient effectively, effective bronchodilator therapy, wait for the response. If he's already on the effective bronchodilator therapy, suspect the cardiac comorbidities at the first onset. This is my practical approach with regard to COPD.
And another important thing, slightly adding to your opinion, I totally respect your opinion, I agree with it. Beyond which, we less often see the dobutamine stress echoes kind of thing in our practice. Probably along with those patients who have renal issues, so carefully monitoring in an intensive care unit, dobutamine stress echo in a cardiac ICU is also would add to some extent to early identify of associated cardiac dyspnea. And another important thing in my practice, I would like to quote is those patients with heart failure with preserved ejection fraction. That is a very, very nuisance in the practice. So once they started throwing, we never know whether it is COPD exacerbation or heart failure with preserved ejection fraction with pulmonary edema. So it is a very, very increasingly challenging task. Sometimes there may be some extent COPD exacerbation, some extent it is cardiac exacerbation and then leading to pulmonary edema. Of course, antiproBNP will help to some extent, but not to a larger extent. So coming to Shachi ma'am, so how do Amitash has covered very, very beautifully in one of his slides that whether we can use beta blockers, how we can use, and then my question to you is how do beta blockers affect COPD outcomes? What are the myths that our clinicians, general practitioners, and pulmonologists should know?
Yes. So there are many myths associated with beta blockers and COPD. First and foremost is there is one myth that beta blockers itself can increase exacerbations and mortality rate in COPD. But yes, this is just completely a myth. We have many evidence now. We have comprehensive meta-analysis study also, where it is actually suggested that by using cardioselective beta blockers, we can actually reduce mortality of any cause in COPD, even by 28% or so, and even rate of exacerbations we can reduce by 37%. So cardioselective beta blockers definitely are very safe in COPD. Even there are some studies which suggest that by using even non-selective beta blockers like propranolol are not affecting much mortality and even exacerbation rates because they are reducing FEV1, but it is very minute. There is very minute change in decrease in FEV1. Okay, so that is very easily tolerated by COPD patients. So it is completely myth that it is increasing mortality or it is leading to increased exacerbations. Second myth is when patient is already in COPD exacerbation, you should not be adding any kind of beta blockers. Again, there are evidence that when patient is already having some cardiac dysfunction or maybe having some cardiac comorbidities and we need to add or if we need to continue beta blockers, it is very safe. Continuing beta blockers actually reduces the days of hospitalization and even reduces the mortality in such cases also. If we need to add a new beta blocker, patient was not initially on beta blocker, but now due to any clinical condition, when he is in COPD exacerbation and we need to give beta blocker, the cardioselective beta blocker we can give comfortably. But yes, we can start with low dose and go slow. Okay. But it is completely okay to even start a new beta blocker. Third is there is one myth that even beta blockers reduce bronchodilator property of bronchodilators. But that is again the same thing. Non-selective beta blocker might do this, but it is on paper historically. Okay, non-selective beta blockers are very safe and they are not affecting the bronchodilator properties of bronchodilators. Yes.
Wonderfully summarized. Wonderfully summarized. My dear friends, please understand, as our lung requires beta agonists, SABAs, LABAs kind of thing. In terms of particularly cardiac issues, heart failure or post-MI scenarios, the global golden rule, as of now, what scientific evidence says is beta blockers, AC inhibitors, and angiotensin receptor blockers. They are the very, very crucial drugs in managing these cardiac patients. So, particularly if the patient is having small cough, or if the patient is having, post-MI scenario, don't, or mild breathlessness. So, don't stop beta blockade. Beta blockers are very, very safe, particularly cardioselective beta blockers. If at all, if you want to start, cardioselective beta blockers play very, very crucial in managing this component. Coming to audience question, we'll take Rajendran Ramasai from Tamil Nadu, Pudukottai, is asking commonest comorbidities of COPD. So, would you like to give a comment on this, Amitash?
Yes, sir.
Common comorbidities, commonest things. You have summarized? Yes. Briefly.
We have already mentioned in the slides as well. All the recent guidelines, all the recent studies, literature shows the cardiac comorbid illness are the most commonest ones with regard to population studies, and it all depends upon the. I showed in my one of the particular slide, the lot of percentage variation is there. Lessly from 19 to 20% to very, as I have somewhere around 60 to 70% as well. It all depends upon the what sort of population we are studying, whether they are the admitted patients, whether they're OPD patients, whether they are the undiagnosed COPD patients we are suspecting, and we are doing spirometry and we are assessing. But yes, with the onset of all this inflammatory cascade, everything in COPD, as the COPD goes for symptomatic and exacerbation or severe COPD grades, the cardiac comorbid illness, since they share the common pathological profile, these are the most commonest, followed by metabolic syndrome. With regard to general issues concerned, especially in the female population, the anxiety and depression scales also were in the higher side. And as we go towards the lower BMI category in the severity of COPD, the anemia, malnutrition, and osteoporosis will get on adding on. So I would suggest cardiac comorbid illness are the commonest, and they have to be diagnosed appropriately and promptly.
Thank you. Thank you so much. And Dr. Hirenappa, so what role does OSA play in COPD management?
See, COPD alone, standalone, is a systemic disease, and that treatment sometimes we have to see outside the chest. It's upper airway, how exactly the airways, if nasal obstructions, obese patients with neck circumference, which is more. So some patients who are having obesity is an important risk factor in COPD. Some patient who is having this, even if they are just having snoring. So normally the cardiovascular reserve will not be utilized in normal patients. They have only OSA. If they are COPD, the reserve is always used. So when they really get exacerbation, the COPD, OSA gets unmasked. That's why we get hypoventilation, CO2 retention and all. So if you have to screen these patients as a regular patients, if they're having a snoring, excessive daytime sleepiness, and those kind of symptoms like OSA or symptomatic OSA, the likelihood of patients having a high probability with the Epworth sleepiness scale more, they have a high probability of doing having a OSA. So those patients, they require, like Dr. Shachi also told, those patients will have simple OSA where they require a pneumatic splint-like device, or a simple CPAP is enough. So we diagnose those patients require a screening. That's a simple OSA, like vanilla OSA, what we call as a simple OSA, which we can treat in OPD. So those patients we should be hunting for. Some patients we do a COPD, we get a PAH which is disproportionate. We get a mild PAH. PAH is unlikely to develop in early COPD. So COPD, when it causes, it's a vascular disease, it's a airway disease, it's a parenchymal disease. If the pulmonary attriation is there, pulmonary vascular blood is less, the PAH starts developing. If that PAH is not explained by your, as you said, the local factors, if it is high, one of the cause, even if they don't have an excessive daytime sleepiness, along with diabetic, hypertension, any other comorbidities, or a previous history of a stroke, or if he has a PSVT or a cardiac this thing, or if the hypoxia, which is on 6-minute walk testing, these are the patients we should, even if they don't have a OSA symptoms with Epworth Sleepiness Score, we need to screen them early and look for OSA in these kind of patients. So PAH, obesity, OSA symptoms, these are the patients we should look for screening for OSA in these patients. Sometimes we have overlaps. Sometimes COPD itself is so bad, advanced COPD, even without OSA, the CO2, because of the poor ventilatory drive, they need a BiPAP.
Right. So another important overlap I would love to ask, is asthma COPD overlap.
Yeah, this everyone is because right. You said it is only a local risk factors. So right. COPD, they are not breathless like status asthmatics. You don't require more of bronchodilator continuously and all. They are calm patients even if the CO2 is 60. For asthma, 40 CO2, they are really bad. They require intubating COPD. These are intubating asthmatics. So asthma COPD, they behave like more of asthma, less of COPD. And they have eosinophilia. Those kind of patients, they really have a tough time getting the treatment with CPAP or BiPAP. Because you have difficulty when there is obstructive airway disease lower down, because the obstruction is there, which is really dynamic obstruction. Fixed obstruction like nasal obstruction, turbinate hypertrophies and all, they are requiring surgery. So this can be managed with the BiPAP, which causes ventilation. But if there is an obstruction there in asthma COPD overlap, there we should be careful of treating the OSA very, very well, because we need to have a good bronchodilator therapy. You need to control his bronchodilators, then only CPAP or BiPAP will work with them. Otherwise, they will pull out the mask. It becomes horrible to treat them. So in those kind of situations, we should be very careful.
And if it is as you rightly mentioned, if it is improperly managed, you will be counterproductive there by using dynamic hyperinflation.
And a lot of rebreathing.
Yeah, brilliant inputs. Now, Amitash, your comments on GRD. Yes, you have given a summary in a slide, but what is your take on GRD? Do you really modify inhaler therapy in a COPD patient with significant GRD? What is your take?
Yes, sir. The GRD and the COPD, the complex, whatever we most commonly see in severe COPD patients. First, to understand the presentation of the patient, there will be more recurrent exacerbations because of GRD. They'll go for recurrent aspirations. Some sort of aspiration pneumonia can also happen if they have some sort of neurological disturbance as well. So, especially when they have some psychiatric illness or something, when they're drowsy and all, they're taking a lot of medications which will affect the central system. As I mentioned in my slides, earlier few of the studies showed like the management of GRD will be a tricky situation, because most of the reflex in case of COPD will be a non-chemical reflex. That's what few of the earlier slides showed. And PPA and H2R inhibitors, in their studies, interestingly, it increased the exacerbation rate. But the recent one respiratory investigation elsewhere publication journal, which showed any of the PPA can be used. Proton pump inhibitors are most commonly used, and lansoprazole. With regard to the inhaler therapy in case of GRD COPD issues, interestingly, few of the studies are showing the short-acting beta agonist, salbutamol and levosalbutamol, they decrease the lower esophageal sphincter tone, and they cause for recurrent this kind of situation, recurrent aspiration, recurrent GRD, and recurrent exacerbations. So, As per the guidelines, after the gold guidelines, if you are going to treat a patient of COPD, if it is not asthma or COPD overlap, very less instances of treating this patient with a SABAS. So effective bronchodilator therapies are there. We are treating with a long-term bronchodilator therapies, formoterol, solmeterol, endol. So most of the times we may not counteract the situation and we are easily treating the GRD therapies. But if you want to take up one molecule which may affect the COPD management in GRD, I would suggest short-acting beta agonist has to be avoided as much as possible. And secondly, the steroid therapies in acute exacerbations, it has to be very adequately tailored. It has to be very appropriately tailored. Better to give a inhaled corticosteroids rather than the systemic corticosteroids if they have a GID component.
So I agree with every point that Dr. Amitash has said. But what is very, very important clinically is, see, whenever a drug is needed to manage COPD, so there is no contraindication. You add additional medication like pantoprazole, esomeprazole, or rabeprazole, along with the prokinetic agent to manage the GRD component. But what is also important is very, very important practical tips, like ask them to at least, space the dinner from dinner time to bedtime, maintain at least 3 hours of a difference, and ensure that they sleep with at least 30 degrees to 40 degrees head end elevation. This is what it is going to work. And more importantly, my dear friends, so addition of anti-reflex, that is Gaviscon like calcium alginate, these kind of things would work in long run. But of course, if you ask me the data, I don't have a data. We all have a very good evidence saying that calcium alginate and then along with PPA with prokinetic. But again, it is very, very challenging. These patients, the moment you stop, because even gastrocolics, they insist on stopping the PPA's usage beyond 6 weeks, sometimes beyond 12 weeks. But the moment you stop, they bounce back with exacerbation. All that we can do is, so probably restart and then, try monitor slowly, ensure the prophylactic GRD measures. So a simple thing like avoiding drinking milk, okay, and then avoiding eating spicy items, masala items, okay, or like this beverage, soft drinks with a lot of carbonic acid, okay. So these kind of things may help in preventing reflux and then thereby preventing the exacerbation. Over to you, Udnur.
I just have one patient with GRD and COPD, a 91-year-old. Now you're treating that guy with PPI and all. He has hiatus hernia, reflex. He keeps on coming with aspiration pneumonia, and the saturation comes. Wife keeps on telling, treat the lungs properly, treat the lungs properly, and all. So the treatment of lung lies in the gut. So unless it is fixed, your aspiration pneumonia, I am treating correctly with antibiotics, with all the antibiotics, off oxygen, I will make her ready. Every time it is happening. And I called the 3 gastroenterologists and I am treating it from past 5 years. How exactly the GID progressed means that PPI, it went on. Then we started doing endoscopies. All this is fine. Then he went into Nissen's fundoplication. With Nissen's fundoplication, he was able to eat. Now he has a reflux after Nissen's fundoplication. Then there was some foreign body which is stuck after nasal fundo in the esophagus. They removed that. So in spite of that, he is having reflux. He is telling me, you treat his lung properly. So now he is going for PEG tube insertion. See, that's how GRD after Nissen fundoplication also. Now he has to eat. He just gets the reflux.
One addition. Even PEG is going to fail in him.
No, at least he will maintain his nutrition.
Even PEG is going to fail in him. Probably percutaneous enterojejunostomy would work, but again, that also can fail.
See, only nutritionally he has lost 3-4 kg. He just want to maintain that nutrition. So he is afraid of eating.
I totally agree with you. Managing GRD is very, very important to prevent exacerbation, to decrease the exacerbation, and then to improve the quality of life in COPD patients. You nailed it, Udnur. And coming to Shachi ma'am. Ma'am, how often do you come across osteoporosis as a comorbidity? And how do you manage your patients? And yes, we have to ensure the better outcomes in COPD patients. How does this management of osteoporosis in your words?
Yes, sir. So, sir, basically, what I see in my patients, around 10 to 15% patients are already having osteoporosis. When we are screening, even they have sometimes asymptomatic fractures also before diagnosing this osteoporosis. So, yes, treating osteoporosis in patients with COPD can indirectly improve the COPD outcomes. Means while we are treating osteoporosis, we are actually preventing fractures, particularly any kind of fractures. But yes, I am concerned more about thoracic vertebrae fractures, because even one vertebrae gets fractured, our FVC, FEV1, even it can deteriorate by 8% or even 9%. So this can affect our they can develop kyphoscoliosis. So it can indirectly affect our respiratory mechanics, which can again lead to worsening of our COPD. If not only about this thoracic vertebrae fracture, any fracture in such kind of osteoporotic patients can lead to immobility, bedridden state, which can again hamper their rehabilitation capacity also. So they won't be getting engaged in good pulmonary rehabilitation programs. So that can again worsen our COPD. Again, immobility due to any fractures or severe osteoporosis can lead to other comorbidities also, which are very commonly associated with COPD, like cardiac comorbidities, or maybe he can develop some OSA, dyslipidemia. Everything can get affected only and only because of immobility caused by osteoporosis or fracture caused by this kind of osteoporosis. Treatment part, I usually, yes.
Yeah, please go ahead. Treatment
prescribe.
part.
Yeah, usually I prescribe bisphosphonates, add calcium and vitamin D supplements where we have already diagnosed osteoporosis.
Right. See, in presence of osteopenia, there is just evidence says that calcium supplementation along with vitamin D, 800 international units per day is good enough.
1200.
But in presence of severe osteoporosis, as defined by minus 2.5 standard deviation from the standards, so these are the patients which we need to manage with bisphosphonates very aggressively, or otherwise sometimes we may need to use parathyroid hormone replacements as well. So otherwise this osteoporosis is going to cripple your patient. One fall, mind you my dear friends, one fall in COPD patients, then very unlikely that he'll bounce back to his normalcy. And yes, Udnur, you are laughing. I have seen you are smiling. Right, I am coming there. Very tough question for you. Statins. Okay, left and right. Statins are used by cardiologists, but we are yet to start statins as a regular prescription. What is your take?
See, statins as such doesn't improve the mortality or anything related to COPD. It will not improve. It will not improve lung function. So COPD patients will have small hearts. No, it is all small hearts. If you see a large heart, they will definitely have a comorbidity.
Right.
So usually it's like that, because when you screen for the EFT and all. So if somebody is having a COPD per se, you don't require statins. Even the guidelines doesn't suggest, because of comorbidities, we need a lipid profiles. If they have people are doing a breathlessness after this COVID, post-COVID, it has thrown a different conundrum to our treatment. This thing, many patients, younger patients, we are seeing MI at 27, 37, like that, with the risk factors. That all risk factors, whatever we read in the books, they are gone for the toss. So people, our own friends at 45, they are doing a CT scoring or CT coronary score and take 40 mg of statins to prevent the risk of stroke. So if there is a calcium score is high. So similarly, when you are giving a statin, not for COPD per se, they are doing like HSRP test. So that's a risk factor for cardiac risk factor in COPD. Those patients can be used as a tool, as a biomarker, and give us statins for those patients at a low dose, 20 mg, 40 mg. So if the risk factors, smoking and the lipid profiles, all these are suggested, that is the proper way of adding the statins. But sometimes during exacerbations, when you see if there is a viral infections, lot of evidence we have seen in influenza, we have seen in COVID, we need to add statins. There was a huge cry about adding the statins when we used to add in ICU. I think Dr. Shachi also knows is there is statins role is there in exacerbations. Not as a routine COPD, it is a how you screen the patients regularly to add a statin, because there are a lot of polypills which are, so we need one ecosprin when we are starting. When you cross 40, we need one statins. Once you cross 40, it's not like that. 75 mg ecosprin, even on a post CABG patients, they are only on 75 mg of ecosprin. So we need statins. The role is there, definitely, but we need to assess it properly with a proper lipid profile, dietary managements. Then only there is a role of statins comes into a picture. But if you screen for USA, we have a CT scores and all. If there is a evidence that statins are going to help long-term morbidity and mortality, we definitely is required.
So Udnur is very clear about when there is alone COPD, no significant comorbidities, there is no role of statins. But if there is associated comorbidities, chronic diabetes, chronic hypertension, chronic sleep apnea, and all other systemic inflammatory components, patients is having probably recurrent exacerbations, those are the patients where you have to think of starting statins. But again, is it going to directly improve the mortalities, making the mortalities better? No evidence so far, my dear friends.
Yes.
Coming to Amitash. Amitash bhai, okay, lung cancer is again, one blow. Naturally in India, for that matter, not only in India, okay, all developing world, there is no proper screening programs. So what is your take? What are the various red flags to identify lung cancer in COPD patients, and how do you take it forward? Quickly, 3 minutes.
Yeah, it all started somewhere in 2011 when the NAGM published that National Lung Cancer Screening Trial. Usually they screen the patients of COPD. It was a very huge study, somewhere around 50,000 patients were screened. Followed recently in 2020, there was a Nelson trial, which was again published in NAGM with the Danish-Belgian study, which screened some 6,000 patients of COPD and 6,000 control patients. The quite difference between these two studies is the NSLT, the National Lung Cancer Screening Trial. It compared the CT scoring versus the X-rays. Whereas the Nelson trial was the CT scoring only, the doubling time, the volumetric CT scan assessments. So just to take the inference of all these studies, what it really showed is tobacco is a common confounding factor. Tobacco exposure is a common risk factor for both these conditions, which affect the lungs, which are equally having a high morbidity and mortality status. Because COPD again is coming to somewhere around 4 higher morbid conditions with regard to all the aspects. Unless tobacco exposure, COPD itself is again an independent risk factor for lung cancer patients. The lot of recent studies which has come up, the airway obstruction, the emphysema on the CT, these are again the independent risk factors for lung cancer. There are a lot of recent studies. I read one article recently on the bronchopulmonology, which was again a Belgian study, which showed the airway obstruction, even the DLCO markers. They had one scoring such as the BMI less than 25, the age more than 60, the DLCO less than 60% predicted, the CT emphysema score being positive, the pulmonary function test. So taking inference of all this, I think the recent guidelines of GOLD 2025, they have given some of the red flag signs. So more than 55 years of age, he has the smoking exposure risk. His BMI is less than 25. His pre-bronchodilator FE1 to FEC ratio is less than 0.7. And he has more than 15 or more than 20 packets of smoking history. Then he has the emphysema on the CT scan. So all these risk factors will add up to the lung cancer screen, the red flag signs. So what I want to tell the audience or whoever is listening to this is, do not take tobacco as the only risk factor. Diagnosis of COPD is again an independent risk factor. The severity of airway obstruction is again a risk factor. Try to do a HSCT scan just to get the emphysema status of the patient. So all these keep on adding. So if they're not symptomatic COPD patients, we can diagnose it early and we can add life to the patient of lung cancer very early in the stages. We may not wait till the symptomatic COPD patients come into existence. So future, we may have some scoring systems which are ready-made like Curve 65 for pneumonia. These are not for lot of screening protocols are going on. And we have to inculcate in our, because CT is very easily available nowadays after post-COVID in all the centers. Our own Indian studies, I think we can do in future as well. Over to you, sir.
So just to add whatever Dr. Amitash said very clearly, so nowadays with the evolving of technology, my dear friends, you need to talk with your radiologist, because there is a component called incidentaloma. That means my radiology colleagues, all are they are my good friends. So I'll ensure that I'll talk to them, and every week they'll give me an update whenever there is a incidentalomas. When they do an abdominal scan, all these abdominal scans will have a lower end of the lungs are covered.
Yes.
So these patients, okay, what will happen is, okay, if there is any red flag signs like something like ILD, okay, COPD with ILD, again is a risk factor. COPD and there is a small nodule, you can identify. And then other important thing in the current world is usage of AI algorithms, artificial intelligence based algorithms. They also help in identifying the nodules at the early stage. And Shachi ma'am, so
Yes.
many patients, okay, the moment you write a steroid, they'll just disappear. Okay. And yes, later on, maybe a month later or few days later, they'll come back and then take the same prescription from you. But what is your take, particularly when you need to write steroids, both oral or inhalation steroids, particularly in patients with diabetes, and say, for example, you are having a patient with uncontrolled diabetes. How do you see?
So, first of all, with inhaled corticosteroids, if you ask me, I'm okay. I'm not much concerned until unless I'm going to give moderate or high doses of fluticasone. I will be worried about his diabetes status. Yes, but baseline, if his baseline sugars, as you told that it is already high, then yes, I'll be controlling those sugars as we treat other diabetes patients. But I know that inhaled corticosteroids is not going to affect much his diabetes status. Secondly, if my patient, I'm going to prescribe him oral or any systemic corticosteroids, then definitely I am very much worried about his sugar levels, particularly the postprandial sugar spikes. So in these patients, usually I prescribe steroids in a single dose so I can control the postprandial spikes particularly. And I use or I prefer insulin in this kind of patients, maybe short-acting insulins or maybe the combination of bolus basal dose like NPH or Mixtard I'll be giving. If required, then I can even give them oral anti-diabetic treatment like DPP-4 inhibitors like sitagliptin, even GLP-1 receptor agonist, exenatide. They are very much helpful in such kind of situations, and they even don't lead to hypoglycemia when I am going to titrate or taper the doses of steroids. Yes, anytime at any point of time when I am managing these patients, whenever I am going to increase steroid doses, then I'll be anticipating the sugar spikes, blood sugar spikes, and so I'll be adjusting the doses of the treatment for diabetes also. In patients who are already very having very brittle diabetes status, as you mentioned earlier, that patient is having very high sugar levels, have frequent decay, a patient is having some infections or maybe is going in decay frequently, then definitely I'll involve endocrinologist also in the management of diabetes.
So essentially what Dr. Shachi is telling is, whatever is the diabetic state, don't worry. Whenever there is a steroid is indicated in case of COPD, whether it is for management of conventional or stable patient with probably echo component, or those patients who are likely to get benefited with triple therapy inhaler. So inhaled corticosteroids are not contraindicated, but during exacerbations as well, if the patient requires oral or parenteral steroids, it is very, very important. You need to give that. But again, looking at the scenario of even DKA or patient is having mucormycosis in the lung, what is important is you need to control the sugars. Tight glycemic control plays a very, very crucial in bringing out good outcomes in this patient. Now, do not worry about giving steroids, but ensure that the sugars are being taken care very well. Coming to next important question to Hirenappa. So, how should the COPD being managed with in presence of CKD patients?
See, one of the diabetic you thought about
Can you please come little close and then talk loud?
Yeah, CKD
Yes.
patients, we will have always, because if they are dependent on dialysis, or CKD may or may not be on dialysis, they just be on the monitoring of regularly with the creatinine. So if they are chronically stable patients or stable COPD, the treatment remains the same. But the CKD patients management, when they are on dialysis dependent, when they really get exacerbation, then there is a problem in managing COPD. Normally, the CKD will be managed by nephrologist, because CKD, whenever they get a worsening of CKD, acute on chronic CKD, there is always a risk factor which triggers it. Maybe it is acute exacerbations, or they may have acute exacerbation with a septic shock. There is a pre-renal component for it. Shock, the renals will worsen. The acidotic milieu, if they are bad COPD and exacerbation, the acidotic milieu, the pH, we are hovering around COPD patients that we should not intubate, because NIV has changed the landscape and we want the patients not to go on a ventilator. We use NIV, CO2 will be washed. So if pH is around 7.25 and 7.35, we still manage, we wash out. But if there is a acidotic milieu is very high, then early dialysis, we are the one thing to prevent the invasive ventilations, because the pH which is dangerous, not the CO2. So the pH can become really, really bad in the presence of CKD patients if they are not on a regular dialysis, or some patients who are sick on this thing. Normally in the healthy patients, when they get AKI, we still wait for a inotropes management, urine output, we give a fluid challenge, Lasix, those things we do. But if a known CKD and COPD patients worsens and he is on the verge of invasive ventilation, there the acidotic milieu, it makes the difference in management, and early interventions with the dialysis and other things are important. We should be aggressive, and these patients have to be, sometimes we think that it is a ward patients. We admit in the afternoon. Yes. So in the night they worsen, the CO2 builds up, acidotic, sometimes they crash and they just worsen, flash pulmonary edema, and those things can happen. So whenever there is comorbidities, we should be very careful in treating, because it's a plain acute exacerbation of COPD in the presence of comorbidities like diabetes, CKD and other things. We should see other organs also has to be taken care, because this MODS, once it sets in, the management cost, CRRT and all those things is a railroading, and the patients really gets on a ventilator, then the ball goes on for 10 days admission, more than we can't wean, then tracheostomy, blah blah, home BiPAP and other things, home ventilations. So we should not make that kind of decisions. So to prevent those episodes, we have to preemptively, proactively see the comorbidities and catch hold out of these things. Even if you are a pulmonologist, you should look beyond the lung.
Exactly. You have nailed it. Another important thing what I need to tell you is, see, when we look at the BiCOP levels, in a chronic COPD patient with CKD component, the BiCOP levels may not be low. So the BiCOP, even in an acute setting, even the metabolic acidosis would have settled in, the BiCOP level still would be okay, around 30 kind of thing. So don't expect just the numerical values. Treat the clinician, treat the patient holistically. That's what Dr. Udnur is mentioning. And coming to Dr. Amitash, see, you have again covered in a smart way about anxiety, depression kind of thing. So what is your take? How does anxiety alter the perception of breathlessness and medication adherence in your practice?
Not only with regard to COPD, with the pulmonary space, a lot of chronic illnesses, maybe it is chronic asthmatic, chronic COPD, ILD, or OSA. Wherever we go, how much effectively we treat the patients will not perceive the effectiveness of the therapy. They are liable to skip the medications. They're liable to go for dropout of the medications. And when we go back and assess the things, especially when the information is given by the patient attenders, so the anxiety and depression will be the counterproductive things whichever is happening here. Just a point to mention, just I'll take 30 seconds time. My thesis topic with regard to my MD pulmonary medicine was with regard to sedation in bronchoscopy. And because of this thesis topic, I had one scale called hospital anxiety and depression scale. Very interesting scale. Some few 5 to 6 questions, simple questions. Is he very joyful? Is he frightening doing his activities? And few of these components already incorporated into COPD assessment tool. Can you confidently go out of your home because of your COPD illness? Is he sleeping very soundly at home? So he's wearing loud pills and all to sleep. He's not confident enough to go home. When we assess the spirometry levels, they are quite okay. We expect that patient to go and carry out his activities very commonly, as we all do. So this is the thing with regard to anxiety depression. The patient perception is very poor. Their symptom control is very poor in spite of giving enough bronchodilator therapies. So unless we treat this anxiety depression very effectively, sometimes we have to take the expert's opinion as well, psychologist and all, because most commonly these patients will be having some kind of insomnia. When they start having these many medications, again the OSA component may add up on, because most of these antipsychotic medications will have weight gain as the side effect as well. So this gets more and more complex as and when the COPD becomes more severe, as and when the comorbidities get added. Again, more drugs, more pill, more anxiety, more depression. Again, the vicious cycle. So it's a very difficult situation to manage. We being the clinicians. So as Hirenappa sir told, look beyond the lungs, and we have to look beyond the lungs and act as well.
So just to add whatever Dr. Amitash said, so I must convey my sincere thanks to one of my mentor, Dr. Subramaniam, who was our cardiology professor when I was doing my MBBS in the medical school, Tirupati. So Dr. Subramaniam was a non-interventional cardiologist. Just by it may be like, you may feel so completely non-medical, but again, putting a hand on the shoulder of the patient, and then giving him, I am starting this kind of medication, explain them, this is a line of management, you will do well. If the mild anxiety, mild depression is there, a doctor's healing touch is good enough. That is what my take. If it is beyond a limit, probably you may need to intervene with medication. Otherwise, I totally agree with whatever Dr. Amitash said. And coming to another important aspect, with so much of comorbidities, the frailty is an important challenge in elderly COPD patients. Shachi ma'am. Can you please go forward? How do you see it and how do you manage it?
Yes. So frailty we can simply see and diagnose. We can detect itself in our busy OPDs only. Like I use simple tools only. I am not using those fancy fried frailty phenotypes or maybe some clinical frailty tests. I just advise like tug test. Okay, so that is just timed up and go exercise. Okay, so I just ask my patient to stand up from the chair and walk for say 2 meters to 3 meters and come back. If this timing is more than 12 seconds, then this already patient is kind of frail. Okay, so this is very simple test. It just takes your 12 seconds. Second thing what we can do is 6-minute walk test, which we usually advise in our patients. So if it is less than 350 meters, then this also can detect the frailty in such moderate to severe COPD patients. This percentage is very high, almost like in 6 to 70% of our COPD patients are having this frailty. When I'm dealing with such patients, I know that these patients are at high risk of exacerbations, hospitalization, rehospitalizations. They would have high morbidities and mortality. So the prescription of medication also depends on this. There is very high chance of drug-drug interaction also. Even inhaler, what I'm prescribing should be very simple. I think so these patients are very comfortable with nebulization only because they are not even able to take MDI with spacer or breath actuated this inhalers also, they are not comfortable with it. So the choice of inhalers also depends on their overall condition. Secondly, I have to concentrate more on the nutrition part also. So actually, I instead of treating COPD, I give them palliative care more in such kind of patients. Even I have to avoid glucocorticoids in such kind of patients because they can worsen their status. Secondly, in very terminally ill patients, I might have to discuss the end of life care also with the patient and the relatives in such type of patients. Even for pulmonary rehabilitation, whenever I'm considering for these patients, I have to tailor it specifically for those patients, which is like very low intensity, so that they can tolerate some kind of at least rehabilitation.
I completely agree with you, Shachi ma'am. So,
Yes.
but pulmonary rehabilitation is one thing which is grossly underutilized in clinical practice. My dear friends, if you identify frailty, so put them on proper, at least 8 to 12 week program of pulmonary rehabilitation. Nowadays, there is a feasibility of doing pulmonary rehabilitation in what do you call video as well. Okay, video consultations are also available, and I must say with a lot of passion. Okay, I do this pulmonary rehabilitation programs on my patients. There are a good number of patients who are maybe having very frail as well, with the successful implementation of breathing techniques and then mastering, strength training and all those things. Okay, at the end of 12 weeks, if they can continue in doing it, there are really long-term benefits of managing frailty in COPD patients. Yes, the hot topic. I don't know. All the hot questions are coming to Hirenappa. What is this? Right. So, yes, I have taken in my talk close to around 12 minutes in explaining the importance of pulmonary hypertension, because otherwise Amitash was looking at me, okay, whether I'm going to cover all the talk relevant to pulmonary hypertension or not. So that's why I had to take extra that 5-6 minutes in explaining pulmonary hypertension in COPD. So my question directly to Hirenappa and Amitash. First, Hirenappa will answer. So, how do we screen pulmonary hypertension? And Amitash would answer, how do we treat pulmonary hypertension?
See, PAH in COPD. See, the PAH, if there is some disease, the most common cause of right heart disease is left heart. So, if left heart is normal, okay, the PAH is normal, no need to worry. If there is a COPD, right from the nose to a airway, so anywhere in the COPD, if it is a parenchymal disease, if it is a airway disease, or if it is a vascular disease, the vascular diseases are the major killer. If the PAH is very high on a first detection of COPD, if it is really disproportionate, on a first instance, the hypoxia, patient is stable, the CT pulmonary angio, we just rule out vascular cause. Pulmonary embolism, acute pulmonary embolism, we treat it. So if they are stable, chronic thromboembolic hypertensions, if they are really high, if they are high, those requires treatment. Normally, those require vascular causes, they cause severe PAH. The next thing, the primary pulmonary hypertension in COPD, it's extremely rare. There are more drugs in the armamentarium, like Dr. Vijay said, we have S400, we have all the things. We have many drugs for PAH, but that is, we really have a less number of nuclear reactor to bomb them. PAH, not necessarily every COPD has to be treated. If the PAH is really disproportionate, if it is not explained to the degree of severity of the lung disease, then there is an additional component to it. One is the pulmonary embolism. The second thing is associated comorbidities. Like if they have bronchiectasis or ILD, their PAH levels will be high because there will be a pulmonary attenuations. So if the airway disease is so bad and they are chronically hypoxia, if hypoxia is not maintained chronically, if they're not using the oxygen at home, their pH will be high. So the tempo of pH going up can be prevented by using a long-term oxygen. Reactive pulmonary hypertension, vascular resistance. If there is hypoxia, there is a reaction. It can be reversible. Sometimes we see at acute exacerbation, the pH is around 60, 70, and on follow-up, when they are stable, it comes to 40. So if it is persistent and it is long-term, we really have to see the pH cause has to be treated. Very rarely we see chronic thromboembolic hypertension, which is proximal, requiring pulmonary atherectomy. They are surgical. That's the only reversible cause of pH. So most of the pH doesn't require treatment. There is a matching of VQ mismatch. When you add vasodilator, we should be very careful. So we should have oxygen at the borderline COPD patients. and 90 saturations, we add vasodilator, the mismatch of matched VQ mismatch can actually make their hypoxic more. So we should treatment also, we should be very careful. For mild PAH, there is no necessity of treatment. We should assess it properly. Echo is the only tool to tell the PAH if RVSP has been detected, detectable tricuspid regurgitations. If at all it is there, its PAH is detectable. So it is a indirect marker. We normally don't do PAH also, you see RARV dilatation. We normally don't do right heart catheterization in COPD patients. Right heart catheterization is not required. If it is more than moderate PAH, whether the treatment is required if after adding long-term oxygen therapy, and if there is any connective tissue disorders, like if you have ILD, there is any other cause for PAH, we should treat that. But if there is all these things are not there, if it is really disproportionate, after ruling out the OSA and other things, this PAH needs treatment. Very rarely, my patients requiring cath studies in our setup, it's not happen unless they go into a lung transplant where PAH, where they require heart and lung transplant. These are the conditions they have the role of cath studies to assess it. Sometimes you do a cardiac MRIs. This thing really, echo is an excellent tool to assess the pulmonary hypertension if it is done by good hands. It is not reproducible. You need a good echo technician.
But just to differ slightly with you, echo is slightly, particularly in the emphysema patients, okay, the poor window because of hyperinflated lung is a very challenge, particularly when you all get trained in ecos in using patients. Okay, COPD patients are quite challenging patients to give a very good report. That's one important thing.
So sometimes PH is really tough. Sometimes you need a good technician and a good cardiologist. You should mention him. I am looking for PH in these patients. Normally, they look at only the left heart EFs.
No, naturally, as a pulmonologist, when we are asking echo, majority of times we are interested in looking for right heart only.
Yes,
so we are less bothered about left heart.
We should insist on them to look at PH. Normally, they don't mention it.
So now I hand over mic to Amitash. He wants to say something. Yeah, unmute.
Most of the things have been covered by Hirenappa, sir. The only difference of opinion will come like the cardiologist should be more prone to treat the PH whenever the patient goes for a referral consultation. Invariably, it will be on echo basis only. They will be treating the patient, invariably it is COPD or special mention is till recently in the COPD guidelines, it was not mentioned. But recently, I think some studies are still going on, long-term studies are going on. So they have mentioned something like in the form of a table in the Gold COPD 2025 guidelines, treatable traits of pH, which can be treated because COPD can be associated with all the types of pH. Maybe it is type 1 pH, type 3 pH, type 4 pH, and as I told, type 2 pH, unless the left heart function is improved. As clearly pointed out by Hirenappa, sir, CTEF is the only treatable condition of pH. Otherwise, all the other conditions, it may be because of dynamic hyperinflation, static hyperinflation, it may be due to other structural lung diseases, it may be because of OSA component adding. Unless we treat with effective bronchodilator therapy, unless we treat the underlying conditions, we are not going to treat the pH effectively. There should not be any hurry in treating with pulmonary vasodilators. As clearly pointed out, ventilation perfusion mismatch will be happening. Treat both these conditions, assess it very thoroughly. If echo misses, again, invariably structural lung disease will do a CT scan. The CT ratio can pick up the pH. So we can cross-verify with the CT ratio and the echo, and we can diagnose the pulmonary hypertension. Some recent studies show some pulmonary aorta to pulmonary artery ratio and tricuspid jet calculation, tricuspid regurgitation calculation. Very good cardiologist can pick up all these things when you do a supervised echo by himself. So all these things are there. A lot of studies are going on sildenafil and COPD can be effectively treated and all. It may correct the pressures, but it may not treat the underlying pathophysiology of COPD. The pressure calculation may be like, if you treat with vasodilators, it may be 56 or 58. When it comes to the next time, it will be 45 or 46. But the symptom management, with the advent of lung transplantation, it is a very crucial topic to treat again. So I think we are going towards little bit of treatment modification unless we are there. LTOT, effective bronchodilator therapy, treatment of underlying cause, then going to other causes.
So this is one area where it is very complex. So I would love to show my slide one more time. to ensure that the confusion is taken off in the audience. So look at this slide, my dear friends.
Yes.
Okay. This is a very, very important slide. I must say one slide if I want to focus on managing pulmonary hypertension or pulmonary comorbidity, this is very, very important slide. You have a patient of COPD. If the patient is having symptoms and signs of pulmonary hypertension, do the regular pulmonary function testing, chest imaging, exercise testing, and echocardiogram. This we have discussed already. But what are the indications of invasive pH confirmation? And Hirenappa rightly pointed out very clearly, hardly there are any indications. But probably in patients who are probably going for surgery, that has CTEP correction or suspicion of severe pH, out of proportionate pH, what we call. And if we want to rule out left heart disease, that also most of the times we can do it with echo itself. So these are the patients where we can refer to right heart catheterization, hardly less than 1%. And what are the right heart catheterization variables if you see? If mean pulmonary arterial pressure is less than 20, definitely there is no pH. Pulmonary hypertension is not there. So manage this as a conventional COPD patient. If there is a hypoxia, consider using long-term oxygen therapy. If the mean pulmonary arterial pressure is greater than 20, then three variants would come. One is if it is proportionate pH, that means mild to moderate pH, then again manage the patient as you are managing COPD and consider using long-term oxygen therapy. And if there is a coexistent pulmonary arterial hypertension, very, very rarely we come across, but there may be associated connective tissue ILDs as well, okay, or out of proportionate pulmonary hypertension. These are the patients at a selective centers, expert centers, we need to use targeted pH therapy. And this is one important pulmonary vascular phenotype, which I have seen in a few patients and also in bronchiolitis obliterans kind of varieties, where these are the patients we can use targeted pH therapy, but again with a expert center only. And coming to pulmonary artery capillary or wedge pressure, arterial wedge pressure, if it is greater than 15, definitely it is a left heart disease. Manage the left heart disease. That's what we need to understand in managing pulmonary hypertension in COPD patients. And coming to last 5 minutes of the discussion as we are approaching 10 time. So Amitash, so I would love to listen to you. What vaccines that you give in COPD patients? And what do you think, vaccinations is going to impact the comorbid outcomes? Quickly.
Unlike any other chronic illness, so we have to vaccinate patients of COPD because it's a chronic lung disease happening, and it's a disease of elderly. So more than 60-year-old. So again, the guidelines mention if it is more than 60-year-old, we have to treat it. And a lot of westernization of our medical science is happening. So we are giving flu shots very liberally to all the every patients. Even the literature supports that influenza vaccination, yearly vaccination will decrease the death rate of COPD due to infective exacerbations. Even it is also protective to COPD comorbidities such as stroke and the myocardial infarction and coronary disease as well. With regard to pneumococcal vaccination, there is some sort of controversies. Invariably, we have to treat this patient with pneumococcal vaccination as well. Whatever the guidelines mention, it is not easily available in our country till now. We have PCV 13 and PPSV 23. If it is more than 65 years, I would like to treat with PCV 13 because studies show it has larger coverage, means it covers up to 3 to 4 years of variation after the vaccination period. And it covers the phenotype which are most commonly involved in the invasive pneumococcal disease. Recent guidelines are also coming up regarding the respiratory syncytial virus, pertussis vaccination, shingles vaccination in case COPD, because all these patients add to the morbidity and the mortality unless they're vaccinated in the adolescence regarding the pertussis vaccination. So invariably in my practice, I advocate all COPD patients, whatever severities they are coming, smoking cessation, vaccination, influenza and pneumococcal at the first onset itself.
Wonderful. Right. Coming to Shachi ma'am. So yes, we have come to the end of the discussion. So what should be the structure of the multidisciplinary COPD clinic? And yes, I'm sure you are the heading it, you are the leading it. What is the conventional that practitioners should do? And after you answer, the additional inputs I'll take from Hirenappa, followed by Amitash.
Okay. So the on the top or the leader always should be a pulmonologist. Okay. He or she should be the one who will be diagnosing the COPD, detecting the severity, even planning the treatment and everything. So the leader would be pulmonologist. The other multidisciplinary, the other supportive treatment will be provided by, first of all, will be the spirometry or PFT technician who will be helping us in diagnosing the COPD. Even they can be used they can teach inhaler treatment, inhaler therapy, inhaler techniques to the patient, and they can even correct their techniques every time when they are coming to follow up. The next person who is very important in this care is dietitian, which can take care about the nutrition part of our COPD patients. The other personnel who will be very important here in our clinic will be a psychologist or psychiatrist who will take care of about the neuro and psychiatric comorbidities, which are very common in our COPD patients. And last but not the least is our physiotherapist and pharmacist. Physiotherapists definitely will be requiring them for a good rehabilitation program for our all COPD patients. And yes, pharmacists who will be taking care of all medications and even looking after any drug interaction or any kind of treatment issues.
Thank you so much, Shachi ma'am. Hirenappa, anything you want to add?
Yeah, I will just add, heart is in the safe hands of lungs, no? And the lungs will always come to a rescue for kidneys faster than the kidney coming to the lung. So this that is my assumption. So whenever we treat in the lung, we are very good in treating the lung. So whenever there is always a comorbidities, when the other specialists treat, we really don't know what anticoagulants they are put. We are into the NOAC and cardiothoracic surgery. If there is a pulmonary endarterectomy, they want warfarin. These kind of indifferences will happen. So sometimes they like only Penegra or sildenafil, which has to be used 3 times. We go for tadalafil. And these are the issues which we are treating. That is a multidisciplinary management. So the concept of treating, which if you are going to treat with anticoagulants, we should not fight with other colleagues and try to give, if it is an anticoagulant is required, so you need to come to the conclusion and give a proper anticoagulant. We need a PAH drug, which is important. Sometimes we fight for ambrisentan, we need for bosentan, we need tadalafil, sildenafil. Cardiologists, cardiothoracic surgeons, they like sildenafil more. Sildenafil more. Sometimes there is limitations. They have a lot of headache with CO2 and other things. They get a lot of headaches when you are using sildenafil. You need a long-acting drugs. These are the things which we are managing comorbids. It's important, especially with the cardiologists, because this new epidemic of heart failure with preserved alveolar function, it is like extraesophageal GERD, laryngopharyngeal cough, or this thing. It is a dustbin diagnosis. No, this is becoming more. One, they don't have the angiogram and the triple vessel disease, which requires stentable is not there and CABG is not required. We'll have lots of problems. So it will be usually COPD. If it is COPD, tell them this thing, it's not no amount of diuretics and all. It needs a long-term treatment. So these are the co-managements which you look at other colleagues. And other things, it needs a lot of other things. As S400 is required, we need integrated system. When standalone S400 is not working, we need other integrated system. This is the integrated system where Vijay started with S400.
Yeah, that is what my conclusion remarks. Yeah, you are saying.
Yeah, this is the integrated system. It's a multidiscipline because you started it. We'll end with this war, which is one Operation Sindoor.
Fantastic. Amitash, you're saying, and then conclusion remarks as well.
Everything is covered. Just my friend will be AI always, because I'll be using the WhatsApp and other things to follow up the COPD patients. Instead of teaching them the inhaler technique, I'll send them a YouTube link about the inhaler techniques, which is made very easily in the YouTube. And repeated assessment of these patients The CAT score is available in all the languages, so we can give the patients whenever they come for the next time, they will tell the symptoms themselves. If they're better with the CAT score, better with assessment scale, they're using the inner better, it makes our life very easy. So as ma'am told, all the other teams are there, including AI, including system. We all have WhatsApp, patients will have smartphones, we all have computers, so we'll make better use of it and better complaint rates. Thank you.
Shachi ma'am, your conclusion
Yes,
remark?
Yes, sir. But this, as sir already mentioned, that it should be an integrated approach. Then only we can manage COPD patients well, because it is like so many comorbidities are there along with the main disease. So we will be needing help of each and everyone, and so it should be very much integrated, and we should be providing integrated and well managed plans to patient also, so they can also be very confident and they can manage their symptoms, their disease also well themselves.
Right. See, all great things comes to an end, and of course, next week CCI will come with this COPD webinar series part number 5, that includes in-hospital management, that is ICU care, non-ICU care as well, and ventilatory care as well. So meanwhile, okay, today I really know I'm super happy, because this is one such concept I was looking forward for any published webinars so far. It is not there. To my best of knowledge, COPD comorbidities has not covered a webinar. So we have done a wonderful job. And please, my dear friends, remember always, these comorbidities are the central chapters in managing in your patient. For an effective, as my conclusion remarks said by Hirenappa, okay, for an effective delivery of AS400, you have to have all the entire integrated system. You have to ensure that who is approaching you, with what weapon they are approaching, with what speed they are approaching, and then you should also ensure that whatever you are deploying onto the enemies, it is deployed and your own system should not block it. So that's why a multidisciplinary team approach is very, very important, because the comorbidities, if you see, I was going through one of the published literature, there are 50 plus comorbidities can be associated with COPD. So unfortunately, another 1 hour is needed to discuss all those comorbidities. We have tried from CCI part to do the best to cover all important comorbidities today, how to suspect and how to manage. And it is very, very important as a pulmonologist, unless you become a holistic physician, it is very, very difficult to identify and manage the COPD comorbidities appropriately. And unless you manage comorbidities, you can never manage COPD. It's not just using an inhaler, starting from monotherapy, upgrading to double therapy or dual therapy, and then to triple therapy. It is not the scenario. You have to identify the comorbidities and then managing, so that you will deliver a wonderful treatment for your patient to bring an impact. It is very, very important. The comorbidities should be addressed. With this, I am signing off, thanking today's sponsors, Meghmani, and then technical team, our Vinod, Amit, Bijal, and then entire CCI webinar coordination team, and then including the office bearers, Ashish Bhai, Anil Bhai, Atri Bhai, Shivani, Kirat, Narayan Pradeepa, our beloved Krishna Anna, and really thank you for giving me this opportunity, and signing off. See you next week.
Thank you. Thank you.
Thank you.